Dr. Kaushik Murali is the president of Shankara Eye Institutions, India. He is a pediatric ophthalmologist, Shankara Hospital, Bangalore. He has multiple publications. He has special interest in myopia management, amblyopia, and community-based interventions. He has been working in collaboration with Harvard School of Public Health, London School of Hygiene on various research activities. And I'm happy to say that he is also part of the team of AIOS who developed the myopia screening guidelines. Over to Dr. Kaushik.
Thank you so much, ma'am. It's a pleasure again to be here. Grateful to KSOS for the invitation to be a part of this session. Myopia, is it important? This little graph shows you the number of publications that are there when you just in Scopus feed and myopia control. And you can see that in 21, it's almost double the number of studies that were there from a few years ago. When you look at the current strategies, the first strategy is in terms of how do you undercorrect. We are very clear that undercorrection results in educational delay and can result in the child being ostracized. So there is no real need to undercorrect, or there's no logic that you should undercorrect. But again, as clinicians, we need to be clear whether we are overcorrecting. This starts off from the size of our refraction lanes. We did a small study to look at the length of the refraction lanes across some of our hospitals, and we realized that the minute your refraction lane cuts down to 8 feet, and today most clinics are of that size, you need to actually reduce about 0.4 diopters or even half a diopter from the correction that you're giving them. The second question came in terms of the height of the vision chart. Sometimes it's at an eye level, sometimes it's higher. What we looked and saw was that the accommodation induced was minimal. So it's rather the length of the lane, irrespective of whether we are cyclopleging the child or not, that you need to be a little wary of when you're correcting them. There have been certain studies in terms of use of bifocals. Unfortunately, the audio is not playing here, but if you look at this, this is a kid where we're given a bifocal, and you notice the way the girl on top is reading. Because she's not able to, she's actually pulling up the chart to read from the top and not use the defocus distance.
Asked me to help the two men carry the box inside. 3 of my friends had never been to a circus before today.
So if you notice her, what she properly does, she lifts it up so that she's reading it from the distance segment. So often giving a bifocal may not be of any use at all to the child. The next strategy is to look at history. Sometimes we do linger a little bit longer in it. But again, strategy is to be clear about how we are defining progression. So in terms of the length, it is age bound. In children less than 10 years, about 0.3 millimeters per year is significant. In older children, 0.2 millimeters should also be considered significant. Higher the power at presentation, the more likely the child is to progress. So that becomes again something very important for us to keep track of. We also looked at saying that from a strategy standpoint, does the ambient light play a role? When we looked at different colored lights, it did not seem to play too much of a role in terms of progression, although the accommodative facility did improve with some of the lights. Medications, there have been multi-analysis that looked at various interventions, and they've shown that pharmacological interventions are the best. Among this, again, a variety of drugs have been tried. What has stood the test of time is atropine. Again, not something new. It has been around from 1900. Literally was used, proposed at that time to paralyze accommodation and prevent progression. This is a non-specific muscarinic antagonist. We are still not very clear about how this works. It seems to have a multimodal action, but somewhere it seems to be working through the D2 dopamine receptors. The ATOM 1 and 2 studies were the ones that showcased that atropine was tolerated and effective, and that 0.01% had minimum side effects and the least rebound. We also, before it was commercially available, did a little study where we reconstituted low-dose atropine and studied it over a period of time, and we showed it to be safe and efficacious. Why this becomes relevant is there will be a set of children where 0.01% atropine may not work. There you have an option of either using it 2 times a day, increasing the dose to 0.02%, or increasing to 0.05%. 0.05% has been tried as a part of the LAMP study, where they've shown that that has as effective as 0.01%. And again, in younger children, it has been proposed as the first modality of treatment. Personally, we don't prefer it in our institute to try it because we've not seen too many children where we've used it twice a day or 0.02 and beyond actually progress. We're worried about glare and the quality of life that these children may have with high dose. There is a current multicentric study ongoing in India, and hopefully that result should tell us. It is always good to advise the children to spend as much time outdoors in daylight. Studies across the world have demonstrated its effect, and this has been made part of the curriculum changes even in countries like Singapore, where it's been mandated that children should spend at least 2 hours a day outdoors in sunlight. Again, we looked at our own population of children who were on low-dose atropine, and what we found was children who spent 90 minutes or more, the progression was much lesser. This difference was even more significant in those who had a family history. Vitamin D again seems to play a role. Getting every child to test their vitamin D3 levels and normalizing it seems to again give some kind of a protective effect, and this again we found it as a trend going forward. Peripheral hyperopic defocus is again supposed to prevent progression and discourage eye growth. There are two ways of doing it. One is using orthokeratology or contact lenses. The second is using defocus lenses. What you see on top, the names are the list of lenses that currently are available in India for providing correction. Not all of them necessarily work. The reverse geometric designs are thought to work better. Again, we've not been able to convince too many children to use it because the use of it is they have to wear it overnight, and although world over the studies have been shown it to be effective, even they have only proposed it in terms of a combination therapy with probably low dose atropine. Again, this is something that you need to wear overnight. Handling care maintenance is a challenge. You need to be able to do a topography. The fit takes time. Most of these lenses are imported in. So the DIMS lenses have, or the peripheral defocus lenses are now coming into vogue. This is similar to your car windshield in a rainy night, where through droplets you don't see parts of it, but the clarity in between still allows you to see what is on the road. So the analogy is very similar to that. So they have built-in hyperopic defocus segments. This little video, if you notice it, you will see little specks of light in the center. And that kind of showcases the defocus elements there. It is still very clear to see. We also looked at so this is the defocus. This is looking through at a topography chart in clinic. The clarity is very good. And again, when you look at children, this is a child that we had dispensed, and we'd asked her to send a little video because we were worried, saying that how will the child be able to run around and do things if the periphery is defocused. This you can see the child happily running around. This is day one of the child actually using these glasses. That has given us a lot of confidence that this works. Finally, you need to spend a lot of chair time talking to both the children and the parents. Most children post-COVID find it difficult to manage screen time. Parents are extremely anxious about progression. Children are unable to find an alternate to screen use. So we need to identify certain ways of doing it and accept that screens are part of life. Again, we looked at saying that what matters is the distance, is it the light. The minute you increase the brightness of the screen, and most parents think that a bright screen is actually harmful to the eye. Look at that child. The minute the screen is bright on the left, the device automatically gets pulled away. And that may prevent the pull-in effect, and the accommodation convergence should hopefully come down. Why are we making such a big deal about it? So what if there is a progression happening? Now imagine if we were able to reduce progression, or an 8-year-old boy with a -1 diopter keeps increasing with time. By the age of 16, if you don't do anything, he may end up with -5 diopters with significant other comorbidities. Hence, it becomes very critical for us to focus on this aspect. Once again, a thank you for inviting me to be a part of this session.
Thank you, Dr. Kaushik, for that very informative